education and educating patients is not a sexy topic, but it is essential. It is fundamental. It is fundamental to what we do, because we don't just do an intervention. I work with a team of neurosurgeons, and their education has to be spot on as well. They're spinal surgeons, they're brain surgeons, all right? So they need to be very clear to the patient why they're doing what they do. But they'll see the patient once, maximum twice, between scans and stuff, and then they'll operate. And then they might see them once for follow-up, and that's job done. So they're teeing them up for an intervention. They do the intervention, and then they stand back and say, okay, your body's going to do the rest. That's not where we're in. That patient does not have to do anything. They have to go to the doctor. They have to put their trust in the doctor, but then their body does the rest. We are asking them to do things. We're asking them to engage. We're asking them to change how they think. That's therapy versus medicine, if you like. And for that, we need a different paradigm for us to work within.
Well done. You have finally discovered the most important health podcast you will ever need as a medical professional. The conversations you are about to hear are guaranteed to change your clinical practice and hopefully transform you into a better conversationalist. They could even make you better crack at parties. Welcome to TCUP, where swearing is guaranteed.
Right, Cork is in the house. I forgot to ask you, do you like to be called Thomas or Tom, or what you prefer?
Either's good.
You don't mind either?
If we're having an evening chat, it'll be Tom.
Okay,
Tom is
cool.
good.
Oh, let's go with Tom then. I think what I'd like to do, I've done before, and I'll go straight into this because it's a highly sensitive and specific validated test I've designed. And it's a 10 quickfire one or the other question, because anyone who doesn't know you will certainly know who you are after these questions. You okay with that? Yeah, let's go straight with it. GAA or soccer?
I'm stumped on that because I played it. No, sorry. Am I allowed to give any preamble, or is it just
no? It's one or the other.
Soccer.
Cork. I thought you were all GAA heads down there.
Well, I know, but there's a backstory. Go on.
I know, this is why they're annoying questions. Coach or therapist?
Coach.
Swearing or no swearing?
Yeah, definitely. Look, I'm Irish. Swearing.
Good exercise or good communication?
Good communication by a hair's breadth. Yeah, I know. Controversial.
No, it's good. You wouldn't be on a communication podcast if you didn't think that, though. So, treating or teaching?
Teaching.
Traditional or modern?
Modern.
Night in or night out?
Night out.
Good man. Italian or Indian food?
Indian.
Prosecco or no secco?
Prosecco.
Yes. Good answer. Good answer so far, Tom.
Yeah.
Waterford or Kerry?
Kerry. Controversial.
Very controversial.
Controversial, I know.
So now everyone kind of either you've upset loads of people or they know you really well, as I've said many times before on here.
Yeah, sure.
Now, what's interesting about your name as well, so I've asked you what your first name is, but you're Dekkers with double K, or is it with an S, isn't it? It's E-R-S.
Dekkers. Yeah.
Now, my next question usually I like to ask people is about, so I'm a big music fan. Do you like music?
Love it.
Yeah, cool. Well, your surname actually is interesting because, well, it's missing the S, so it's not the same, but when it brought me back to when we, especially around Christmas time, because we'd come in from, it used to be Mass actually back in the day, and you'd come in and my dad would play records. He'd play different types of records. It'd be Irish music, sometimes country and Western, which is another thing. But he'd play loads of Desmond Dekker. So he used to love Desmond Dekker.
Yeah.
Desmond Dekker. So that's what I saw you. But you have an S on the end of yours, so yours is different.
Yeah. Me and Des, we don't have any links with Desmond, so no.
You've got no royalties.
Not at all. Dekkers is a Dutch name. My father's Dutch, so
that's what it is. With the S. Oh, cool. Whereabouts in Holland?
Yeah.
Is it the Netherlands? Oh, and
the
I know.
metal
Are you
Beethoven, yeah.
PSV fan?
PSP, we have a couple of shirts in the locker, yeah.
He's trying to
Yeah.
brainwash you.
I know, yeah.
So on that, then I've had my chat. What kind of music would you use to describe your therapy style? Or does music help you relax, switch off, do anything like that when it comes to you being a therapist or just a person in general? Do you use it for that?
You know, therapy helps me with everything. So, sorry, therapy helps me with everything. Music helps me with everything. So I'd have music, different music for different phases of my day or different phases of my brain. So if I'm doing some deep work and I need a bit of concentration, I'll listen to something with a beat. I'll listen to something like a bit of progressive house with a little techno vibe in it, not too heavy, just something to keep me on. If I'm lifting weights, it'll be rap. I'm veering towards UK rap these days, and if the sun is up, I'll do a bit of reggae and a little bit of R&B. The sun isn't always up in Ireland, so we have to mooch around
It's never up.
And if if I'm being more social, then there might be something like a bit of an acoustic vibe going on. So yeah, depends on the day, depends on the time of day, depends on the weather, really.
Cool. Nice one. Well, that's a similar answer to a guy who's been on the podcast, Andy Hosgood. He would mood regulate, which I think is quite important because, as a therapist, I don't know how much people, look into how their mood affects their maybe communication or how they're going to be with that patient and how much they have probably more control over it. And so I'd like to get your thoughts on kind of how you maybe the day's not going well or you're trying to get motivated or, you've got that difficult patient coming in. Have you got any kind of strategies to help you kind of get through those kind of times, or do you use anything like that?
Yeah. I'd start with a bit of progressive house. Get my beat going. And then what really just helps is actually just having a stand back and having a think about the patient, because inevitably, I think what can be sometimes hard, you see that there's a challenging patient coming up and you've got patients before them or you're busy before them and you just fall into the appointment. You haven't got a plan and the patient starts unloading their story and, they might be no better or something. And, so if you've had a couple of minutes to think about them, think through a couple of scenarios, the whole thing just goes smoother. If they're not as well as we'd like them to be, I might go down this channel. If they're doing well, great, there's a progression. And the funny thing is, when you're prepared like that, sometimes they come in and surprise you and they say, geez, I'm doing great. And then it's, high five. And if they're not, then you have a plan up your sleeve,
Yeah, that's cool. I like that because that's very similar to me, and I've never verbalized that. But that's exactly what I've done. I've done it for a while, actually. That's so cool.
Yeah.
Because I went, that's the thing. It's like what I used to have a certain personality type that would be really difficult to manage, and I don't know what. There was a moment when I went, I have to start to love these patients or do something. I can't keep, there's something in there that I can't spend, 30% of my caseloads like this. I've got to sort this out, And then that was exactly what it is. That kind of idea is like, what's the best case scenario? What will I do if that happens? What's kind of like, not too sure, kind of in the middle, if you like, or may not be so good, or what points from the last time do I need to maybe remind them of, and have that, and then shit hits the fan type thing. What we going to do here if it's a dead rubber? Like, what conversation do I have to have? What questions I have to ask? So I think that's a great thing for a therapist listening, going, right, do you do that? Because as you said, you can sometimes, especially when you're qualified first, you said, as you said, bowling into the next patient. And you're a bit like kind of like you just go with it, don't you? And you haven't really it doesn't do you any justice, does it?
No, it doesn't. And not only that, but it hangs over you all day. You're kind of building up to it, and then it's kind of like a self-fulfilling prophecy because the whole process is harder if you haven't had time to think about it beforehand. So then, it kind of speaks to itself then that was a hard patient, and then the next time they come in, it's nearly worse. So you have to break the cycle. And if you have that couple of minutes to break down their presentation, understand the bigger picture, I suppose it gives you a bit of distance between the emotional component. So you can really be more objective with what's coming out of your mouth. It allows you to stand back from it a bit. So it's very helpful. So really at the beginning of my clinic day, I'll sit down, I'll look at the patients come in, I get a blank piece of paper. I don't do it on computer because I think better when I use a pen. And I write down 3 or 4 bits per patient about where each are going to go. Takes me about 7 or 8 minutes, and that sets me up. That's all going well.
Yeah, brilliant. Yeah, no, I'm very similar. Yeah, that's I think people could take that away. I think it's so simple. It doesn't take very long, and you get in that habit.
Absolutely.
It clears it up. It's a bit like, I think people often bring patients, like problem patients to me, and I'm like, you're trying to find out where it got to cruise mode. They've seen them 7 or 8 times, and you're going through it, and you went, what happened is usually, what it is normally it's handover patients, like they've been handed over by somebody else.
Yeah.
That's usually a little, and I'm like going, straight away, that's the one where you just didn't really, in my opinion, like build that connection or understand the patient. You've just kind of gone, all right, I'm hoping what the last person gave is just going to happen. And then it's just I'm just going to like take him off and it's going to be fine. And then it doesn't. And then you're like, oh no, wait a minute. I haven't done a proper look here. Do you know what I mean? So I think that's great. What do you think about that yourself? Do you get, when you're supervising or when maybe physios, because do you employ people?
So I don't own the clinic anymore. We sold our practice a couple of years ago. So we'll have plenty of student physios and more junior physios in the health service where I work at the HSE here in Ireland, and then in private practice as well. So there's definitely other physios around, and some physios will come with their patient towards for a second opinion and stuff like that. So there's plenty avenues there for kind of coaching and teaching around that.
Oh, what? Yeah. So on that, that's kind of probably what I meant to say was like, so do you see any kind of common trends in the difficulties patients or physios have around, bringing you problems? And you can be like specific to, like, you run a lower back course or spinal course. So it's if you want to make it more specific around that, but do you see any trends in the problems physios face and then how you might solve them? Or do you see any trends in that?
As in the problems they have personally with their own patients?
Exactly.
Yeah. So look, at this stage, I'm nearly exclusively spinal in my caseload. The odd ACL sneaks in because I've been around for a bit, but at this stage, it's predominantly spinal. So the predominant issues that people have with spinal, and it's the first thing I always ask on my course when people come on, is like, what are the common problems that people have? And so a common answer will be around the psychosocial problems that people have. Maybe patients have very ingrained beliefs, and clinicians find it hard to break those beliefs or to change those beliefs. That's definitely one. People find getting people to engage in exercise for longer periods of time and keeping them going through a longer rehabilitation program, they find that challenging. Or getting them started at all in the first place, actually getting them, to adhere to a program can be very challenging for people. And just understanding what the hell is going on, I think, is reading between the lines what a lot of clinicians struggle with. I think a lot of clinicians are very happy to clinically reason from a pathoanatomical, biomechanical point of view, but putting the picture together when you drop in things like pain mechanisms, psychosocial factors, lifestyle factors, that's when it starts to get very messy, and then people can get lost, particularly with the guys who are, highly persistent pain with loads of comorbidities. It's like the patient unloads a huge pile of info, and then people kind of get lost with, where do I need to put my focus, because there's so much going on here. So those would be the 3 big ones,
Yeah, no, absolutely. Can I unpack that last one then a little bit about that kind of idea of, so kind of like from your standpoint, maybe come at it different ways. Like, what questions do you ask a patient that are not medical, or what things do you say or that are not medically for, you're not asking about their pain, you're not asking about red flags, you're not asking about pathology or mechanisms. What other things are you asking, or how do you ask them that you think is like nearly like non-negotiable, really important to ask, or that maybe unlock patients? Do you have any nuggets there?
Yeah, Yeah, there'll be a few. The first one is I'm very picky around their physical goals. Like what do they want to be able to do, or what are they not? What is causing them problems at the moment, or what are the what are the physical factors that are causing them barriers towards getting to where they wanted to get to. So they might have an issue with saying, look, I have an issue with walking. Back pain bothers me walking. Okay, well, how long of walking before you get back pain? And then they have to be more specific. Okay, fine. Let's say 10 minutes. How far would you like to walk? I'd like to walk half an hour. I'd like to walk an hour. Okay, so now I have a defined physical function. I have a current outcome measure. You're walking 10 minutes, and I have a future goal. You want to be able to walk 30 or 60 minutes. Okay, boom. That's in my program. That's in my needs analysis of where I need to go towards towards the end. And there's a very I can elaborate on that. There's a really important reason why I kind of get granular with that. So that would be one thing. The other thing I asked them is, what is their understanding of their back pain? What do you think is going on? And that's a very open question. Most, if not, all the patients I see these days have seen another clinician. In many cases, they've seen multiple clinicians. So physio, chiro, osteo, GP, rheumatology, surgeon, pain consultant, you name it. So they've gathered a lot of information from different clinicians with different expertise. And, have they got a really good understanding, or a plausible understanding of their symptoms at the moment? And so many don't, actually. So yeah, I'd be very clear with those two things: good physical goals, and understanding. Does that patient understand their pain? And then, they really set me up for what happens next then. But I can elaborate in wherever you need me to.
Yeah. Let's maybe do that while you're there, because there's a few other things I'd like to say. Yeah. So that you said you wanted to get a bit granular about the goals and why you dive into that so much. What can you maybe expand that a little bit?
Yeah, sure. So I think that really comes down to the fact that when people come to see us, right, 999 out of 1,000 will come to see us because they're in pain. And they'll come to see us because they want to get rid of their pain. So if you ask someone by the end of your initial consult, the end of your subjective assessment, and you say, okay, what would you like from me here? What would be considered a good outcome? They'll all say, okay, I want my pain to go away. I want you to get rid of my pain. I want my pain reduced. I just want to wake up tomorrow and not have pain. All right. So we know they want pain reduction. But what they don't always say is would a good outcome in their physical function look like? So in order for them, I get them to verbalize it, get them to give like a marker. And then where that goes is that in future sessions, we can start to work towards that. So I know in my management plan, right, when it comes to prescribing exercise, improving function, encouraging people to achieve their physical goals, I'm very confident as a physio and as a strength coach that I can improve someone's physical function, unless their pain is really astronomical and they've got huge barriers. But in the vast majority of people, if we program their exercise program right, and they can put in a certain amount of work, they will see physical improvements. All right. That is different from saying someone with a persistent pain presentation that I'll definitely reduce your pain. And so when I first qualified, I fell into the trap that I'm sure a lot of people have fallen into, is when a patient with persistent pain comes back to you and you ask them, so the first thing I would ask them is, how's your pain? And they would say the same. And then the next session, they'd come back and say, how's your pain? The same. And everyone is losing heart here. The patient is like, I'm coming back to see this guy multiple times and my pain is the same. The therapist, me, is like, Jesus, physio isn't working. We're all wasting our time. And we're missing a huge avenue there to say, well, pain isn't changing, but your physical function is. So this is a win. We're actually working. So I will now ask patients, how's the walking coming along? How's playing with the kids coming along? How are the exercises going? Do you find that they're getting any easier? Yeah, I'm now lifting a little bit more weight. Okay, brilliant. That's positive physical outcomes. As we start to draw patients' attentions away from their pain and show that they're making impacts in the physical domain, in the functional domain, they a lot of the time their pain will naturally reduce with that, but it doesn't tend to reduce if they stay stuck in this, how's my symptoms today? What's my rating of pain today? So I use that specifically to kind of engage them in that and channel them away from symptom checking and being too hyper vigilant around their symptoms.
Yeah, cool. Yeah, really good. And that's one thing I do as well. Like, sounds very similar. Is kind of give them a kind of a visual as well. I don't know what you think about that, but I would say I'll raise my two hands like I'm doing on the camera here, and I'll say, oh, look, your pain is this amount. Let's take whatever, a jar full of pain, and this is your level of function at the moment. So that you've got this for this. This is how much you can do. This is how much your pain is. And what we're going to focus on is at the moment, because you've had all this treatment and it's really not got anywhere, especially for those persistent pain patients. But if we can just, like you were saying, just we improve this a little bit, this may not change, but you're getting more for your money, if you like. You're getting more for that kind of pain buck. So, and like you said, it's like the difficulty comes when you're kind of going, so what happens if we get up here is like going, well, the pain could stay where it is. So you've got more for your money. But what's likelihood is that all things, your mindset will change, your beliefs around your pain will change, your confidence will change. And we do have evidence around this and some certainly beliefs in that affects pain. So therefore, that's so it's kind of nearly, I don't know what you think about using a visual cue as well for people, just alongside what you've been saying, is that importance of getting what's important to them, what they value, and then getting them to be able to understand that, because it's difficult for them, isn't it?
Yeah, absolutely. And I'm definitely all about the visual cues. You've gone for your dials on the decks. I use the curve. All right. So
Okay.
so I'll say, look, what we learned is that your pain comes down and your function goes up, and you kind of hit the end of the scale, and you're good. They don't come down at the same time. So we might see that in the initial stages of your program, 6 to 8 weeks, you're going to see improvements in function. Then over time, you might see a reduction in pain. And it's not so much that, I suppose I want to qualify that, not so much that I'm trying to negate their pain or push it under the mat. Like we listen to them, we understand their pain, but I want to draw their attention slightly away from it. And where we want those programs eventually to go is that as that person naturally starts to focus on function a little bit more, their symptoms of pain may reduce a bit, but what we actually start to see is that their symptoms bother them less. So the way I'll finish the conversation is, look, what we'll see, you'll get more physical improvements. Your pain might come down a bit, but what I also want to see is that, it's likely that, realistically, you might have a degree of ongoing symptoms given that. But what if I told you were able to walk your hour, you had a degree of pain, but it just didn't annoy you as much. It didn't bother you as much. Most patients are like, yeah, I'll take that all day long. I can handle a bit of pain if I can do what I want to do. Boom, I have the patient lined in there. And that really speaks to setting good, clear goals that are realistic at the beginning, because otherwise patients get annoyed. I'm seeing this guy 3 or 4 times. My pain is staying the same. And if you haven't set them up initially that of what they're going to expect over time, you'll lose them. And I think that's one of the key reasons why people feel like people don't engage in longer rehab, because they haven't met the person's expectations. And part of that is that they haven't set the expectations for the patient.
Yeah. There's 2 things there I want to kind of mention. One, that comes back to your third problem that you'd said about, what physios or therapists would say to you on your course, how do you get that initial motivation, that adherence to what you want, because you've already built that relationship up by setting, or what coaching models will say, you've contracted them. So you're sitting there, and I think, again, I might have mentioned this. I bore myself with this stuff, but contracting is so important, and I don't think it's done as well in our world. It's done really well in the PT world, where they kind of like, I've told the story many times, but I remember I won a competition, and I was with a trainer, and so she was setting me a program. She set me through all this information, and it was like really laying out all what I wanted to achieve in quite big detail, and then I had to sign it at the end, like a proper contract.
Nice.
It was really, it was good, like, because I was like, oh shit, this is, I was like going, and I kind of went, this is what we need to be doing. Like, not, I'm not going to, there's a certain area and time for it, but certainly you can explain it. You don't have to get patients signing contracts, but the same thing you're talking about there is that early conversation, and then being like, look, we both want a result here. What does that result look like? How specific can we make it? And what's it going to make you feel like when you do achieve it as well? Can you see yourself, doing that thing? Which again comes into something like visualization or whatever, which again can be tricky depending on what type of patient you have. You got to be careful with some of that kind of stuff, I suppose. But it's just that idea though, from the word go, everybody knows where they're at. Makes a massive difference.
Yeah, absolutely. So I will finish the initial conversation with them, and I'll say, all right, so if we could get you back to doing a bit of housework, so a bit of hoovering, get you back to walking, or if you're an athlete, get you back on the pitch with less symptoms, but being less bothered about your pain, would you be happy with that? And they'll go, yeah, great, happy with that. Everyone will take that, particularly if they've had pain for a while. The thing about that is I don't write it, and because as a personal trainer would, which is a really nice way of doing it, it's a little bit different maybe in a clinical environment that patients might get a little bit scared with that. So they'll have said that on day one. Then we go into the rehab part. The other part that I'll tell them about is that obviously this is a lovely, graph of function improving, pain coming down. But the reality of it is, improvement is not a straight line, right? Is it? It's a bobble. It's a bounce. There'll be peaks and troughs in it. So I'll say to them as well, I'll set them up like somewhere along the way, your symptoms are probably going to flare up. We are asking your body to do new things or getting it to do things that it hasn't done in a long time. So there is a likelihood that your back might get sore. When that happens, my job is to keep you going on the program. We'll find a way to navigate around this issue and get you back on the program as quick as we can, rather than going right down to the bottom, taking a month off everything and then having to start again. All right. So I get them set up for that. And I said, you might also feel at times that for weeks you're doing stuff exercise wise and you're not seeing any benefits. And said, that's okay. My job then is also to keep you going, to get you through those sticky patches. Okay. If I work with an athlete who's an Olympic athlete and their time horizon is 4 or 8 years to the next Olympic cycle, they have sticky points in that. And it's no different for someone with persistent pain. The patient gets that on the initial consultation, but then they forget about it, right? Until it happens. So then 8 weeks later, that patient has a flare, and I say, do you remember what I said to you day one? This is going to happen. Okay, I understand. We'll get you through this. 2 weeks later, they're back where they were, and they've leveled off for a couple of weeks, and then they're going up again. They level off and they go up again. And that initial consultation, I don't always get around to a load of treatment on initial conversation, but I give them all of that information, and I send them an email with a couple of bullet points. This is what we've discussed. This is what I think is going on with your back. These are the strategies that we're going to go ahead with, manage it. This is the time frame we're looking forward to seeing you on the next session. So maybe that's like a soft contract, I suppose. I don't get them to sign it, but it's in writing.
I think the signing would be a bit and you're right, because we are dealing with people in pain. We're dealing with sensitive information around. It's definitely, in my opinion, different than going to get fit and go to a gym. The environment's different, sure. The background's different, and I would agree with everything you're saying there. It's just very clearly agreed, and I think there's so many things there I wanted to kind of talk to you about. It's like, this is the thing it's why you said communication was more important than exercise when we said that at the beginning.
Absolutely.
Right? Because if you get that right, it makes the good exercise even a good exercise, in my opinion, anyway.
Absolutely.
So,
absolutely.
And what you're kind of looking at that, how many times you'll see it, don't you? You get patients who come in and you could draw, you'll say to them, right, how has the last few months gone? And they'll draw literally a zigzag of, I did this and then this happened. I did this and that. So it's like, I did loads of stuff and then I suffered, and then I did loads of stuff and I suffered. And like you're just saying there, is you're trying to reduce those peaks and troughs. Yes, you're trying to do more, but it's a gradual thing. And then you are really preparing somebody's mindset for this bump that they're inevitably going to have. Now, as you said, they do forget, but when you remind them, they're like, oh no, oh, you did say that. And then in my opinion, that's another, again, like a trust. This is, they predicted this. This is okay. This guy knew what he was talking about. Do you know what I mean? It says that to them in some ways. So they can take that a little bit, and hopefully that, so it's a form of trust building, isn't it? Because they've been here before. Whereas if you've not
Yeah,
mentioned it and then suddenly you saying something, it might feel a little bit like you've just made it up. Do you know what I
absolutely,
mean?
absolutely. Yeah, and you've said it to him. And the other thing you've said around that is, I'll be specific around, when does their symptoms normally come on? All right. So we said if it's 10 minutes of walking. So that person will come in. I had a lady last week. How's your pain? I haven't seen her in a few weeks. Oh, it's the same. It's the same. I just had a really bad week, a grumpy week. I said, okay, so how are things like? How's your sitting going? Oh, I don't really have any problems sitting anymore. I said, oh, that's interesting, because 8 weeks ago you said you could barely sit for half an hour. Oh, did I? Oh yeah, well, you're actually right. Yeah, I am. I said, how's the walking going? I don't know, I'm walking about 45 minutes an hour. I said, yeah, look at my notes, 20 minutes on the first assessment. All right, great. So all of a sudden her symptoms haven't changed. She's had a grumpy week. Work's been stressful. It can be very much, this isn't working. If you have it notated and you're granular about where they are initially on day one, then, her entire demeanor changes. And she's a patient who was probably coming up to the second or third appointment thinking, this isn't working. Now I've got her, and she says, all right, this is working. And now we've just bumped up her program to a more advanced program, and she's bought in again for another few weeks, and she'll continue to get the gains. So that's one of those sticky patches that we'll see with patients, where you just need to have reminded them, pre-warned them, tell them, and then tell them again.
Absolutely. I call that improvement greed. So that when they don't realize how much improvement is, because it's those ones you come in and they sit down and have a big sigh, and instantly you're like, oh no, all right, this isn't plan B, quick. And then you realize, and then they say, they go through what they're doing, and you kind of write. I always write on a whiteboard, and I was writing it up like, okay, yeah, sure. You're kind of like, oh, so your heart comes back to life again, and you're like going, do you realize what? And you can see them kind of, but then that's the power of like measurement and feedback, isn't it? Again, it's why, if you can get numbers, like they're so useful for people for a load of different reasons, but that is because their memories are shit. We all are, you know what I mean? Well, people forget, I suppose therapists, you forget, like, you don't want to have a little bit of pain. You want to be completely better, or you don't want to be just a little bit better at football. You want to be back to football. So until it's back fully, it's not better. Do you know what I mean? So, and they forget that, and that's our job to kind of keep them going. Do you know what I mean?
Yeah, and keep, of course they've got the big goal, 6 months, 4 months down the line is the big goal. I want to be back to X, but our job is to shine light on the small wins along the way. All right, so that, okay, well, you're now walking 15 minutes more than you were a few weeks ago, or now you're now running 5Ks where you were only running 3Ks a while ago. They are all wins. You're not running 10K yet, but can you see that there's a trajectory? Because what we do in therapy, it's not an overnight thing, right? And certainly people who've had long-term issues, it's over a course of months. And so the strength of what we do is really to get people to engage over a long period of time for the more complex patients who are the vast majority of my caseload. So this is the stuff that I would say on a regular basis. And honestly, when people say I have trouble getting patients to engage with exercise or adherence, I really don't have that problem. That's not arrogance. That's just, I very much think it's because I've educated them day one, and I've educated them day one about where what's going to happen over the next few months. I've explained their back pain picture in a way that makes sense to them, and so they know where my exercise program is dedicated towards that. I'm not just giving them exercises off the shelf. You've got an issue with this, or you want to be able to walk, so this is the exercise program we're doing to address that, and so they understand where it's going. And then of course we can get into the whole prescription of how you manipulate that around the individual person, which I find fascinating, and it's my passion is the exercise. So when you ask me education or exercise, my knee-jerk, my academic interest, my passion is really around exercise prescription. It's what I teach on my courses, etc. But the best exercise program in the world, the best thought out program in the world, is minimally effective if you don't communicate with the patient effectively, because if they don't do it, it's for nothing.
Yeah, it like you can't ignore that. It's interesting though, Tom. When you people go on your course because they're gonna. You can imagine a lot of them are right. Tell me what about the pathology, the biomechanics. That's what I want to know. I had
Sure.
Ben Cormack talk about this as well. Like therapists lose their shit over biomechanics, is in to quote him. Whereas when it comes to like, we get some new information about empathy or listening or communication, and the evidence is pretty strong and pretty good in that area, it's just doesn't hit home. He says it even on his social media if he puts something, but it's mad, isn't it? Because we're social animals, communication is so important of, everyday life. So I think we were trying to say, and it's not tangible, and maybe we don't value it because it's difficult to put a value on it. And it's so organic at times, even the conversation we're having here now. And I was listening to a podcast earlier on today, and they were kind of saying, even if you write it down, you mentioned writing it down, writing your stuff down. I'm the same. It kind of, if you write it down, it feels different. But when you're talking it out loud, it's there on the spot. It's quite raw. It's quite vulnerable in some ways. Do you know what I mean?
Yeah.
So I think people feel a bit vulnerable about that aspect of what we do. And therefore, if you can put it into boxes and say, right, we ask these questions, that gives us these answers, and then we complete then out the other side, we spit some exercise. And I think that, when you're learning, it's quite nice to have some sort of structure. But when the more experience you get, you understand that structure is quite confined,
Yeah. So structure, I suppose I like to work within a framework, and that framework allows plenty of space around it. But the essentials of what I do are very similar between each patient. So I educate, I try and explain what the issues are in a way that's meaningful to them, and then I employ strategies towards the dominant underlying factors of their symptoms. But how that manifests in each patient is very different. What comes out of my mouth is very different. My manner is very different. And when a lot of people on the course, when I ask them what do they like out of the course, what do they want out of the course at the beginning of the session, they'll say, "Oh no, I'm here to learn new exercises for back pain." Listen, I could teach you new exercises for back pain all day long. You can go on YouTube and learn exercises for back pain. The most important thing you'll get on my course is the understanding of why you would prescribe this for this particular person, because then you can use all the stuff you already know. It's not about the new technique. And I've done this in my earlier career. Of course, I've gone on tons of courses trying to find out a new manual therapy technique, or if I just learned how to manip, maybe I'd be better. And yes, you pick up these tools and these tricks and these new techniques, but ultimately, the most important thing is the thought process about what you want to do with that patient. And that gives you so much more freedom to use all your existing skills when as I said, maybe the needs analysis for that patient. Then we don't have to be saying, oh, this exercise is so much better than this exercise. Maybe both exercises will be beneficial for this patient, but in different ways. But you won't know that unless you've done the deep work beforehand. And it's not sexy, right? Clinical reasoning has never been a sexy topic. Education and educating patients is not a sexy topic, but it is essential. It is fundamental. It is fundamental to what we do, because we don't just do an intervention. I work with a team of neurosurgeons, and their education has to be spot on as well. They're spinal surgeons, they're brain surgeons, all right? So they need to be very clear to the patient why they're doing what they do. But they'll see the patient once, maximum twice, between scans and stuff, and then they'll operate. And then they might see them once for follow-up, and that's job done. So they're teeing them up for an intervention. They do the intervention, and then they stand back and say, okay, your body's going to do the rest. That's not where we're in. That patient does not have to do anything. They have to go to the doctor. They have to put their trust in the doctor, but then their body does the rest. We are asking them to do things. We're asking them to engage. We're asking them to change how they think. That's therapy versus medicine, if you like. And for that, we need a different paradigm for us to work with it. And that's where communication, I'm not saying our communication has to be vastly better than a surgeon. Everyone has to have good communication in healthcare, but how we pitch it has to be very different, because we're trying to breed engagement in what we do. And that is a very, very hard thing to do. And that's a very subtle thing to do. And it takes time, and it takes a lot of mileage.
Like there's definitely a couple of things there. I use a very similar example with orthopedic surgeons who I work with. It's like their intervention is that person is either asleep or half asleep, and they do the thing. And that's their intervention. Our intervention is behavior change. It's commitment to stuff. It's a lot more to do with our communication when it comes to the intervention, whatever about finding the information about what's wrong. And there's lots of nuances in why people may have pain that don't have a surgical solution. So you've got obviously they've got a surgical solution to things. If that doesn't fit that very tight framework, it's either is or it isn't for surgery. They make the reasoning around that, but basically it's like, I don't think it's for this physical reason. We don't have that, and it's very, very difficult. And the kind of pushed on your point about exercises, and the same thing goes for me. Like, people come on strength and conditioning course because they want to learn more exercise, and I'm like, exercises have not changed at all
since the Roman times.
100, yeah, exactly, yeah. I was going to say 50, 100 years, thousands of years. Like the movement patterns, how you load up. People have been doing this for a long time. You're suddenly not going to be like, oh, so you got these type of that persistent pain patient. You haven't done this exercise. I can't believe you haven't done this one. Do you know what I mean? Otherwise, we'd be all. It'd be like a bit like if we could scan everyone and we'd find everything that was going on. We'd just scan everyone, wouldn't we? And so that kind of the interesting thing is exercises haven't changed for 1,000 years, but communication is the fastest growing thing that's happening, and it's why we are the top of the food chain. We communicate in groups, and now we can communicate in absolute every aspect of the world. So social media is the fastest growing kind of communication there is, and it's constantly changing, and then it's constantly manipulating for us to engage in it, and it's so addictive for us to connect with people via this. There's pros and cons, obviously. So again, right in front of our eyes, communication is so entwined at how important it is for us to buy and sell and whatever we're trying to do and educate. But actually, people still find it hard. That they think that, all right, I need this exercise that Tom's going to give me for this back pain patient, which it just baffles me. I keep asking people the same question, why that happens, and I'd just be interested to see why you think people struggle with it, or did you struggle with it in the past and something changed your mind over that?
Yeah, and look, the first thing I'd say with that, as like, what you teach as well in your strength and conditioning coaches, there is a lot to be very specific about in exercise. If you take it as a premise that at the very least, if you give the wrong exercise, inverted commas, you can cause someone more pain. All right. So if we can say that, then somewhere in that continuum, you will at least give an exercise that doesn't give them more pain. And then from there on, you might give exercise that might improve things a lot. But it's not so much about having a bank of 3,000 exercises. Actually, you can be a really good physio in back pain if you have 50 exercises or 100 exercises for low back pain, if you understand the reasoning behind it. So I think there's a need to have a bank and have flexibility in your exercise programs to be able to mix and match and jib and jive depending on what your client needs. And certainly if you work with athletes, you need a wider range again. But there is an upper maximum of probably what you need, and where then the most gains you're going to get is going to be about your reasoning process behind why you choose what you choose. And then the big one is, how do you mediate that to the patient? How do you communicate that with the patient? So, get really good with exercise prescription. I'm a huge advocate of that, and I think physios have not been good at that historically. I think we really need to embrace all that, the exercise science and the exercise physiology in there, but don't look on it as a standalone intervention like a surgeon doing an operation. It comes hand in hand with good communication. They are hand in hand, no matter what environment you work in. Otherwise, they fall flat in their face. And ultimately, I tell a story of a patient who I saw a few months ago. I saw him in my neurosurgery clinic. So I work in the neurosurgical triage with the surgeons. They might have been waiting a couple of years to see us, and because of the waiting list, right? Patient comes in, he has not seen anyone other than his GP. He's been sent into the neurosurgery service. He's got axial low back pain, no radiation into his legs. His scan looks pretty okay. So I'm saying, look, this is not going to be for surgery. We don't need to do any more imaging. Look, I think what would be really beneficial for you is a good rehabilitation program, exercise program. I pluck patients off my neurosurgery list for myself to do the physiotherapy. So he would be one person who I said, I think you'll do very well. So come and see me. my waiting list into public service is about 6 to 8 weeks from the time I refer to myself, if you like. So he rocks in 6 to 8 weeks later, and I say, sorry, I should say that before that. I said, he says, is there anything I can be doing in the meantime? I says, well, look, your weight might be an issue. As he said, you work as a bus driver. He says, I just don't get up as much in the day. I used to be in the arm. I used to be fitter. I said, look, all right. So what kind of time do you have in the day? And keep in mind, in my neurosurgery triage clinics, I've literally got no time for intervention chat, but I can give them a few minutes, right? I give them 2 minutes of chat. All right. He says, I work 12-hour days in the bus. I says, how long is your circuit? He says, it's about a 2-hour trip, and then I get a 15-20 minute break. I says, all right, in that 15-20 minute break, what are you doing? I'm sitting down. He says, get up, go for a walk, go eat your sandwich standing up. And that's all I told him. I said, go and do that. That would be an option for you. He comes back 6 to 8 weeks later, says, my back pain's completely gone. I said, oh, really? I said, yeah. He says, I said, what did you do? He said, I did what you told me. I got up on my breaks. I went up. I've been walking. But then what I've done now, I've started getting the hang of it. So now I'm going for a walk before work. And you know what? Now I'm looking at the lunch I'm eating. I'm realizing that's not healthy. So I'm now eating a salad at lunch. I'm walking more. I'm getting up more. I'm walking before work. And you know what? I bought a couple of weights, and they were on special offer at the supermarket. And I started doing stuff that I used to do when I was in the army a few weeks ago. The guy came in about a stone lighter, with less pain, but he's also had a huge behavioral change, right? And so that took about a minute of talk. And I wasn't saying that necessarily that he would be asymptomatic when he walked in the door, but he took the ball and ran with it. Okay, so that is the power of education. There was no fancy, you need to do X amount of reps or sets. I just told him get up and move more, and the guy did it. That's not going to be the same for every patient. Some patients certainly need more around that, and because he had a large exercise base in his past, he could probably tap into that. But it probably goes to show that if you can educate people early and they do what you ask them to, or when they say do what you ask them to, if they believe enough in what you're saying to create behavior change, that's the goal. That's the goal right there, if they can do it.
It's so interesting because, yeah, really interesting, because about 15 minutes ago, I thought I wanted to ask you a question, which was, like, I have my opinion on this, but like, how much percentage, if you were to do it, if you were to play a game, and we don't know the answer to this, but if you kind of to play a game with this, is percentage of what we do as therapists with regards to reassurance and how powerful that is. So it's interesting. You just told that story. It literally was reading my mind. It's like, how much would you like to chuck into the percentage that what we do is a whole bunch of reassurance, and how that affects pain? Or you don't have to say how it affects pain, but how much do you think you would say that what we do is a lot of reassurance?
Yeah, I'd say a fair bit. I'd say a lot of people come in very scared and worried that, they're going to have pain for the rest of their days, or that the pain is something serious. I can't count the amount of people who, when I talk them through their scan, or I de-escalate their fears, they're so thankful, and that leads to a domino effect of them just getting on with their life and doing more things. So I think it's a very large proportion of what we do. And again, I come back to maybe what the surgeons do, which is a very distinct, very high risk, high gains procedures in surgery, but it is one intervention in surgery within that, and they might give some advice around that. Our intervention, so to speak, is a really kind of messy thing without edges. So it's reassurance, it's education, it's exercise, it's behavior change. It's very hard to quantify. I suppose in an individual patient, you can quantify maybe this is what I think they benefited from the most. But it all comes out in the one ball, doesn't it? And ultimately, the really good long-term outcomes is that, if you bump into a patient 3 or 4 months post rehabilitation, when they've been doing well, if they're still doing exercise or finding something that they enjoy doing, they're managing their symptoms, they've managed flare-ups, they're doing the stuff that you've kind of rehabbed them with and coached them with for a number of months without you, I think that's the greatest gift we can give to our patients. I think that's really that's what I would consider a successful physiotherapy program. if we can get to the level of behavior change in the absence of active therapy, that person can do it without you. That's a really powerful thing, because that's a lifelong skill we've just given them. That's a lifelong opportunity for them to get healthier, and that affects not only their musculoskeletal system and their pain, but it affects every system in their body, because we know exercise is the best medicine on the planet.
Yeah, and like what you're saying there, if you're talking, especially if you're listening and you're in private practice or run a private practice, whatever, because like within HSE or NHS, patients are, there is an issue with regards to the fact that the patients will be there regardless of your quality. And if you get a job in those jobs, you're there. Patients come and go. The quality is very rarely measured, which is a problem. But let's just take, for example, when I moved to private practice as well. So I do half and half, as I said to you, and the big learning point was and it helped my NHS job as well, because it just brought up that standard of care in some ways. That kind of like, why was I doing my job? Why do I buzz off what I do? What's the kind of, when do I walk away going, why am I doing this? Sometimes you kind of like, oh my God, why am I doing this? But just like what you said there, is that kind of lifestyle change where you've literally had a huge, people talk about charity work or doing stuff to change people's lives. Like, you can literally give people another lease of life, who will then tell other people, who then will then send their friends or family and come back and go, we heard that this was a really good, you did a really good service. Now, if you're a therapist and that doesn't make you buzz, then what? I'm not sure why you're a therapist, because that's the buzz, isn't it? I don't know about you. It's that kind of idea that you've done a really good job, and that the people are telling other people, and they're sending their loved ones or friends to you to kind of do another good job. And that will only breed nearly motivation as a therapist to kind of get better, isn't it? It's kind of like a way. Sometimes you can be, I've been stuck in a rut when I was started off the first few years in. You can get a bit like churning patients out. It's hard work. So how do you get your motivation as a therapist to really make a difference? Or because you're still lacking some of the knowledge, you're still a bit unconfident. But just that idea that if you could, that one patient, you just, reassurance and doing that well and educating people can really have a big effect. And I think it's more powerful than people probably give it justice to,
Yeah, absolutely. I mean, so much so, it really is the reason I do it. The reason I love being a clinician is to to help people. But that sounds almost a bit contrived, but it's the truth. There is a buzz. There is a physiological, psychological buzz that you get when someone comes back and says, what, I'm just great. I'm great. Thank you very much. Don't need to see you anymore. Good luck and thanks. You can go home. You've really made a positive impact on someone's lives. And I would say that the interesting thing is, from day one of being a physio, you might start to have those experiences, right? You're going to get happy patients coming in the door. For me, that was always a huge positive to the work I did. But for me personally, the added bonus or the added thing that I personally need in my practice is to understand, and you probably as well, to understand why that's happening. Because, I started to, certainly in my early years, question whether I was being effective or not. Why is this patient getting better and this patient isn't getting better? Is physio just all a bit of a murk? Is it all a bit, woo-woo? Not many people know that about me, but I nearly left the profession after 3 or 4 years, and I had my application for medicine because I wanted something more physiologically based, and thankfully Toby Hall talked me out of that and told me go to Australia for my master's, and I learned good clinical reasoning. I learned to understand the patient. I learned to make the features of that patient fit, and so now, although my interventions are quite broad, I can kind of understand a lot better why the person presents the way they are and why they're getting better and how to get them better within my paradigm. And so to get people better and to know how you're doing it is the beautiful thing for me. It's the science and the art, really.
Well, there's a thing that links me and you is James Moore a little bit, because obviously we run the, and when you were saying that, there was one of those kind of, I don't know, moments. I'd been qualified a while, and I got a job as a hip ESP. And my hip surgeon had said at the time, he went, "Oh, I've just listened to a guy who's physio at a conference, and he was excellent. You should check him out." And I was like, "All right." So I looked up there, and he was like Mark Young and James Moore's course back in the 2010 or something like that. And So I went on it up in London, and it was the first course I memoed. I recorded all on my phone, like every single thing, and then sat and typed it up afterwards for like 6 weeks, just so I could get all those. Because I'm not very good at taking notes down. Like it was epic.
Sure.
It was like I would. I don't know if I'd suggest it to anyone because it took a lot of discipline. But the reason why I mention him is because what you just said there is that, you know, you went away and did your master's, and that understanding then led to that kind of like, it's that kind of like, oh, right, this is quite cool actually. I've got some sort of, you got hooks into it now that gives you that confidence to build on it. It's the foundations, if you want to call it. And James's course, I just remember going, all right, now, and he talked about exercise prescription in a different way than other people did. And it was not the same. And I remember going, all right, okay, this could be done like this. So it's amazing when that happens. And I think if anyone's listening and they're not, they're a therapist and they're just a bit like, well, I'm not too sure. It's like, maybe you just need that, you know, go seek people out, and hopefully through like even courses like yourself and stuff, it's there's clinicians out there that will make you, you know, it doesn't have to be a master's. It can be a 1 or 2 day course or a webinar or something you listen to and you're thinking, actually, you know what, I could hear more from them. And that can really unlock your kind of future therapist, you know?
Yeah, absolutely. So I suppose the, you know, James is the other reason I didn't quit being a physio either. You know, I met James when I was about 3 years qualified, and he came to teach with us, and he just, he blew my mind with the amount of information, but how he was putting it together. And so he took a lot of influences he takes a lot of influences from different fields and puts them in. And ultimately, it's a demonstration of an expert clinician pulling the research together into a clinical picture. And that's really the special sauce. All right. And that's what I got in Australia. There was a lot of people who were just pulling, you know, because we can all read the anatomy book, we can all read the pain science literature, but can you pull it together in the individual patient, make it make sense, and then apply your interventions? That's clinical practice. That's clinical expertise. That is nearly impossible to write down. And so you have to see that in action with somebody and see what real life clinical expertise looks like. And that probably brings me on to a little bit of a of an issue maybe that I have it's just the way it's gone with evidence-based practice. And as someone who's doing a PhD, I want to understand that more, and I understand the need for evidence. But, you know, back a couple of decades ago, you know, Jeff Maitland and these guys at IFOM conferences, they would get up on stage and do, you know, patient demonstrations, and they would demonstrate their reasoning in front of people. All right. And today's conferences, we don't do that as much, right? It's about the evidence, it's about the research, which is essential for us to progress as a profession. But it's also leading us down a track of, if there's no reference or article that can justify what I'm going to do, then I shouldn't do it. And you work with someone expert like James, and he's, you know, thinking completely laterally outside of the box and pulling concepts from different areas of medicine. You really need to see that in action to become a good clinician. And you see the discord between research and clinical practice. And if you look at the original definition, I'm on a bit of one of my old hobby horses here, but the original definition of evidence-based practice is the unison of the clinical expertise, you know, the research evidence and the patient's individual predicament, not just being able to spout the evidence. You know, because I've read so many papers for my PhD at this stage, it doesn't necessarily make you a better clinician unless you're able to apply it in a certain way.
Brilliant. I couldn't agree more, and I'm glad you said that. I was actually going to ask you a question about PhD, so you've answered it really, really nicely. Just at the end there, which is really good. And I used to say, I made a little cheesy line with the only P your patient cares about is presence and not a P value. So you got to sort that out at the start. You know, anyone who doesn't know what a p-value obviously is relevance to significance in research. But the idea is that it's great having all that research, but without that presence, without that understanding that we talked about at the very beginning of the podcast and throughout, then without those contracts, without those ideas of where that patient believes in, where they're going, or you can have all that, as you said, all the exercises, all the evidence for that. It's not going to work without that other bit. And as you said, if you can see clinicians like Peter Sullivan, Kieran O'Sullivan and the likes of James and people like that at play when they work. It is, you got to get experience. There's nothing like seeing somebody who's just been able to, as you said, just kind of take stuff and just blend it into a conversation and be natural with it as well with a patient, because that's the other thing. Is like, they're human beings. They're just normal people as we'd expect. We need to speak in their languages. Sometimes, as Absolutely. I say, sometimes a swear here and there is perfect for that patient, but completely not for the other patient. You know, whether you're asking about your children is perfectly understandable in one case and then not for other people. So I think what you said there is really great way to wrap up the podcast, and I appreciate that, because again, I'm really looking forward to hearing the results of your PhD. And I think you do some great stuff, and I think people should follow you and be a disciple of Tommy Dekkers. So if people should check it out, and I really appreciate your time, pal. And unless you want to say anything else, is there anything where people will get you? Where's the best? You got some courses coming up or anything like that? It depends on when this is going to be released, though. That's the only thing. But what's the name of your course again?
The rehabilitation of back pain. So it's the fusion of my interests around back pain, clinical reasoning, and then the application of exercise medicine to that problem. So so that's currently a 1-day course, but coming up to be amalgamated into a 2-day course coming up in 2025 post PhD or during PhD. I'm working at two things at once. So people catch me. I'm in the UK, I'm in Europe, and in Ireland, teaching that on a regular basis. I'm on social media, Instagram and X. I always call it Twitter, but X. More on X than Insta. But you never know. I might feel a bit more love in the Insta and get more involved into it. But I find that the X format a little bit easier for me. And then my website is thomasdekkers.com. There's a lot of free info on that. I've done a few talks over the time, so they might be helpful for people. But if I could finish on one thing, it would be for people to experiment, to be okay, to be creative, and to have confidence in what we do. I suppose that's the moral story. I do this with patients, and I teach in back pain because I love it, and I love it for those reasons. A, because it's a challenging problem solving thing for my brain, but also because we can do great things. I think we can really have great results. And ultimately, I work in a service with 5 or 6 neurosurgeons, and in that triage service where I see patients who've been referred, who have maybe failed conservative treatment, inverted commas, gone from their GP, had pain medicine, come to surgeons service. You know, I looked at my stats recently. Only 2% of my people who I see in neurosurgery waiting list will go on to have immediate surgery. So, you know, I would say comfortably less than 10% of people walking in the door into a designed spinal service are having surgery. So that's 90% of the people walking in the door with spinal pain who aren't appropriate for surgery, and a good shot who aren't appropriate for pain medicine, or pain medicine will have a moderate effect. So we in the therapies and physio are the spearhead and are the people who are going to manage the bulk of these, and we can do it very effectively. I didn't say cure, but we can manage them very, very effectively. So I'm very passionate about that, and I probably want to finish on that.
Lovely. My on fire, as they say in Ireland. Good man. Thanks a million, Tom. Great chat. I'll see you
Pleasure.
Again.
Bye-bye now.
Cheers, bud. Bye.
Thanks for listening to TCUP. If you liked it, tell all your friends. If you didn't, well, maybe you'll like the next one. Go to procareeducation.com or Procare Education on Instagram for more information on courses and the Bamboo Project. And remember, always be sound and not a dickhead.